Yeah, good evening. It's my great pleasure to share the same dais with Dr. Keki, Professor Keki Mehta. Thank you, AIS and RGIS, for giving me the opportunity. And once again, I express my gratitude to AIS for governing body to organizing wonderful academic session last almost 1 year, more than 1 year. And today's my topic is biometry for premium IL. What are the critical factors? And we are going slightly reverse. Actually, Dr. Ganesh discussed lots of things regarding the premium biometric critical factor. I'll skip my slide. I don't think there is a repetition. I I have no financial interest to disclose. The goal is basically cataract surgery, restoration of clear vision. But goal of the premium oil implantation not only the restoration of clear vision, but also the correction or significant improvement of presbyopia, and it's a correction in linear sightedness and of astigmatism. These are the considered as the IL premium IL, but it definitely varies from doctors to doctors and patients to patients. That all surgery are premium and all lenses are premium. But these are the commonly talked about the premium IL. And I consider all the multifocal, lead off, trifocal, or the recently introduced in the market CRV IL when the ATR in the TK is almost, I will discuss the TK already discussed. TK, what is the value of total keratometric value? It's 0.75 or WTR 1 diopter. But more than that, I will prefer to give the any platform with the toric platform. So look at the defocus curve. If you the landing zone of these diffractive oil or kind of diffractive oil like trifocal oil or EDOF oil, landing zone error of margin in biometry is the very less. So if you see that this highest vision logmark chart is achieved in the near emmetropia with the 0.5 plus and minus. And if you once able to land in the emmetropic zone, then when it's everything will come in right position. So if you miss that, then it's very difficult to satisfy the patient. So patient selection is free, and you should be very critical. Right lens for the right patient, but with the invention of the new technology or trifocal, already discussed that your range, we are not so critical like we are previously with the bifocal IOL. So we are more and more reluctant and easily implant the EDOF and trifocal IOL due to the excellent technology of the lens optics. So apart from this premium critical factor, the patient selection, biometry formula, biometry machine, aberration measurement, angle kappa, and the surgical factor also very important to give the perfect result. So let us talk biometric consideration. I will talk about the biometry formula, a little bit of a literature review, biometry reports. I understand the biometric report, how to see the biometric report, how to see the validation of the report and the biometry machine. So, so the lens, the quest started almost 75 years back when the first lens was implanted and came out with 20 diopter surprise. So since then, the biometric evolved from SRK to the newer generation formula. You can see these are the SRK1 and SRK2 has a fixed ELP position, considered a fixed ELP position. But after the third generation formulas came in the early 80s, 1980s or late 1980s, and this become use the variable ELP according to the K or axial length to determine the ELP. And later it is when Koch adjustment came in much later. And the fourth or fifth generation, these are the multiple variables which use to detect the ELP. So these are the classification formula for the base of the derivation. The regression formula is SRK1, SRK2, and these are the divergence formula. The divergence formula is basically a theoretical formula considering the Gaussian optics. So two variables is SRK2 holiday 1 and Hopper Q. Here is the 7 variable in holiday 2 and the 5 variable in the Barrett universal 2. The ray tracing, this is a new concept introduced by the Olson, and also it is in the FECO optics. It is a different, slightly different kind of formula, which is also invented by the Dr. Olson. And these are the new concept of the ray tracing technique. So I just discuss these little bit, these new formulas little bit. The holiday 2, they use the 7 variable axial length, K reading, white to white, Q of refraction, patient age, lens thickness, and anterior chamber, 7 parameters to detect the ELP position of the IOL. So it is the most popular formula before 2010. After then, the holiday, this a new formula is become more popular. Olson formula is a new concept of the C constant. It eliminates basically it eliminates the ELP with the relation with cherometric value, axial length, white to white. He came with the C factor, the constant factor. This factor actually decides where the lens is sitting, and it detects the actual ELP position. The ELP is decided as a ACD plus C into the lens thickness. This is this came into the market in the 2011, and it is published in the in BJO in the large data, almost 1,000 cases data in 2014. And it is only available so far in the Lenstar platform, biometry machine. The Hill RVA came into the in 2016 or late 15. It used the AI and regression analysis of very large database and for the refractive outcome of predictive IOLS. And it is also free. It is free and also available in the ACRS daughter. It is a huge database on database, and it is increases over time, and it is getting better and better every day because now this is the Hill RVF C data just released and derived from more larger data set, expanded biometry range, and it Hill RVF biometry also taken into the consideration with the ethnicity, the gender, and now it is Asian statistics, Asian data also available. This Hill RVF formula is basically dependent on the axial length, K, ACD, CCP, white to white, lens thickness, and gender. Remember, this is not a formula. It is a database. It is a matching with it is a pattern recognition. It gives you inbound whether this prediction value is reliable, and the value are highly probable within 0.5 targeted outcome. Outbound means the data showing prediction value is not matched with targeted outcome within 0.5, or there is not enough data to validate. This is not a formula. It is validate your result. It is actually came from the huge database and give you your correct result. And this is a RVF calculator. Looks like it is free in the ACRS website. Now the KM formula, it is basically combination of artificial intelligence and the theoretical optics, and require all LK, and gender. This also available in the IOLformula.com, available in the website. It is a free, and comparison is the same in BJO published in 2018 and 19. The other comparison came with the existing formula for the intraocular IOL power. This is the latest formula which came into the market, and now this is the most popular formula, IOL formula for last almost 7 years. This become the most popular formula. Barrett Universal 2, already discussed, part of the discussed by Dr. Ganesh, is based on the theoretical model I, and it taken into consideration principal plane A change in the principal among the variety of IOL by the means of lens factor. Furthermore, it estimates ELP based on the antechamber depth, lens factor relation to the actual position and the location of the principal point of the different oil path. It has also utilized the five variable. It is a axial length, keratometry weighting, and antechamber depth, lens thickness, and what to white to measure the ELP. Barrett uh, and it's also available. APCRS is a free to use, and everyone can use this Barrett 2 formula. So these are the all formula. When we are considering the premium IL, which formula is we should use, and whether we should use the multiple formula, and it is a really needed so different formula depend upon the different anatomical condition of the eye. There is a long study by Dr. Millis et al., which published in 2007, and it answers almost all the questions. And because this is a very peer, accepted peer publication, because it has a huge database, it started with the more than 37,000 cases, but ultimately finished with the almost 27,000 cases. And it implemented only in the studies on the axis of single phase and axis of IQ platform, that is SS6080 and SS60WF. And he categorized divided into C group, less than the 22.5 axial length, and 22 to 25.5 and more than 25. We also divided keratometry subgroup, less than 42 and more than from 42 to 46 and more than 42. And he compared Barrett Universal 2, Olsen, SRK2, Holiday 1, Holiday 2, Hopper Q, and Higgins. Let us start what we got from the first answer we got from this study, which formula is most accurate in all range of eye axial length. You can see that in this case, the Barrett also the clear winner, almost more than 50% cases is within 0.25, 0 to 0.25. And if you consider the 0.5 to 0.75, it is almost 94%. And nearest is also is Olsen. And other formula is much behind. And now the second question is which formula is most accurate in all range of axial length? And here again, the Barrett, you can see the blue color is less than is a hypermetropic eye. Normal is green color indication, and the myopic is more than 2.22, 5.5 is the myopic. And here is the almost Barrett has the almost accurate result in all kind of length, all type of axial length. And next is again also become the next. And whether we just actually believe previously that the Hopper Q is good for the small eye, that is a smaller eye, but here you can see in this study, Hopper Q has a significant error in the shorter eye. And next is the IOL power from the, you can see the red line, it is Barrett has a consistent result up to the 28 diopter, 28.5 diopter in the chart. It is almost near the baseline in all. Next is the again Olsen. Olsen gives us a consistent result also. And this is the comparison the axial length. If you consider the smaller eye, and all again the Barrett is a more consistent, followed by the Holiday 1. Holiday 1 is a very good give the result in when it comes with a very smaller eye. And also and all the lens, all the other biometric formula almost same. But if you come to the slightly larger eye, it is a 24 to 28 diopter. You can get the again Barrett is a more consistent, and second is Olsen, and you can see this is a Holiday. Holiday 1 give the Holiday 1 is give the most erroneous result in the longer eye. So which formula, again, the question number third and fourth, which formula most accurate in the eye of all range of keratometry value? And the question number four is the all kind of anti-chamber. Again, if you see this Barrett is the more consistent, and after that, it is the Higgs give the most consistent result according to anti-chamber. Then, contrary to the belief where the Olsen calculation depend on the C factor is depend on the ACD, but this is seen that the variation in the Olsen value. Probably Mill is explained this is the earlier formula of the Olsen he used. Now the Olsen has come out with the newer formula which is available in the refractive optics platform. Probably they explain this phenomena because the Olsen has the most variability with the anti-chamber depth. And keratometry average again the Barrett and Holiday gives the good result. So, what is the effect of Van Cox modification axial adjustment? You can see this is a. I just skip this slide. You can just see the SRKT. SRKT has definitely there is an advantage. Otherwise, in the longer eye, SRKT going to the hypermetropic postoperative diffraction. It adjustment there is a definite is a myopic diffraction. So the Van Cox adjustment is really needed for in higher axial length for these formulas. Again, you can see the Higgs. There is a hypermetropic shift in postoperative diffraction almost all the cases, but its adjustment is myopic patient is a bit wrong. But in Higgs, this adjustment actually not very helpful. So it's Barrett in the is the more acceptable and gives the more accurate result in all kind of length, all kind of axial length, all kind of keratometry value, all kind of anti-chamber depth. So why the Barrett is so popular? If you use so it came to the prediction that when you are use only one formula, it is better to use the Barrett universal 2. And again, it's a very good synchronizes the one of the best Toric calculator, that is a Barrett calculator, and Barrett 2K, which is already discussed, partly discussed. It is very good formula in post laser cataract in post resolution correction. But now it became the total keratometry value, which improves the Barrett result further. This is the TK universal 2, and there is also is coming the TK Toric calculator and Barrett TK. This TK is basically game changer of the IOL calculation. This Barrett TK formula is really give a excellent post-operative outcome in all kind of premium IOL. The purpose of TK is to replace standard keratometry, aiming to help reduce the outline and improve the refraction outcome of the IOL calculation. And probably in the coming future, this TK universal 2 will replace Barrett universal 2. So, what should be the postoperative refraction in case of premium IOL? And in my case, in phase by correcting IOL, when I use the TK, then my bifocal IOL minimum myopic refraction in case of Barrett universal 2. But when I use the TK, I use minimum myopic spherical equivalent. It gives very good result. And even in the trifocal, if I use the TK formula, Barrett TK universal 2, I use the myopic minimum myopic spherical equivalent. And if I use the Barrett universal 2, it is minimum myopic refraction. And for EDOF, I keep my patient slightly myopic, at least 0.75 myopia in spherical equivalent in the first eye, that is in dominant eye, first eye or dominant eye, or non-dominant eye, I keep at least 1.25 spherical myopic spherical in the EDOF IOL. And toric IOL, I always try to for ATR I always try to give the minimum residual cylinder at slip axis, and WTR because I want to correct ATR more, and WTR are minimum residual cylinder at same axis. So biometry journey, we have come from ultrasound to sweatshirt biometry. So it's in our clinic, workflow should be biometry should be done always in bilateral, and it should be done pre-dilatation biometry, and it should has the investigator name. So training of the investigator who is doing the biometry is very important. He has to validate the biometry report whether it is coming right or wrong. I am giving some biometry value. You can see this is at least trifocal. It's a normal length of axial length. And if you see the Barrett, Hill RVF, and also almost give the same result. Sorry, this is almost the same result in all cases, whereas the SRKT has give slightly different from the Barrett or Olson or RBS. And TK is this is a TK. How you see the IOLS 700. This is a anterior curvature, and this is a posterior curvature reading. Here is a 0.9 because it's a W tier, and definitely when the posterior axis is deducted, it is less what it's showing. So if I go for the this is a validation, how to validate your biometry in IOLS 700. It's a nice tool. Your investigator must know how it gives the accurate result. It's a fixation check. You can see that telecentric reading in the biometry, but here it is not actually perfect. And let's see what biometry result ultimately gives. You can see this keratometric value is uncertain. If your investigator goes through the whole report, that machine give you automatically, and it validate your report, that reading automatically. This machine is actually give everything that you can check at least 5 points whether you are taking right biometry or not. If again you see that axial length, there is an exclamatory mark, and that means there is a fixation loss. Again, in IOLS 700, it is automatically calculate the Barrett TK toric. And as I said, when I use the phase biopic correction lesson, that is a trifocal, I skip to the lowest biotic spherical equivalent. And when I use the biometry, you can see I use this green, that is universal 2. That is I always prefer to give some amount of myopia and residual. So ultrasound biometry, if in a premium IOL, today's scenario has no role because we are not able to use the all kind of latest formula here, and definitely so it has no role. You have to use either optical biometry or surface biometry. The optical biometry has a disadvantage, often is also very good, but often fails to in PHC in nodal point. Very small PHC in nodal metal, optical biometry fail to give do a biometry. And ability to penetrate advanced cataract is not possible in case of optical biometry. And surprisingly, in IOLS 700 and can give almost accurate biometry result, even almost very advanced cataract, almost in a mature cataract. So, and unusual eye like lens still can detect in IOLS 700. These are the advantage of the IOLS 700. It is accurate axial measurement, lens measurement, 3-zone keratometry, posterior keratometry, total keratometry, ACD, AQL lens thickness. It gives the CCT, white to white, angle cup, angle alpha, and reference image for markerless surgery to attach with the Calypso marking system. In conclusion, Barrett Universal 2 or Barrett TK Universal is the most popular and well accepted formula for the premium oil, even in all kinds of oil. And Hill RBF with the AI-based database formula will improve constantly over time because it increases almost. Hill RGF 3 has almost more than 30,000 data, and it will improve over time definitely, and it gives a more accurate result. And so, biometry is the instrument choice. It's better to invest a little more in the SWIFT rather than for the future. Thank you so much for your kind attention.